Today we're going to be talking about the ST segment. The ST segment is this segment here. So from the end of the QRS complex at the end of the S wave here until the start of the T wave. So this is very important when we're talking about myocardial infarctions. We can see both ST elevation and we can see ST depression. So this is going to be very important in ECG interpretation. So first of all, let's look at the ECG that I put on the last video, the axis video, and let's go through the standard steps to work it out. So starting off with a rhythm, so we have two small squares, three big squares, we have the same there, so we can say that this is a regular rhythm. The rates, well, it's between 3 big squares and 4 big squares, so we can say that it's between 75 and 100 beats per minute. It's about halfway, so we can narrow it down and say it's between about 80 to 85 roughly. Next, we're going to be looking at the P waves. So we can see a P wave there, P wave there. This is V1. So this is where we're typically going to see upright P waves, V1 and lead 2. Again, lead 2 has upright P waves. And so the P waves look to be in quite an abnormal position. They're pretty far away from the QRS complexes. What we need to do in this case is we need to map out the PR intervals and make sure that they're regular. So in this case, there's about 8 small squares between the P wave and the QRS, and it looks to be pretty similar here. And again, the same here, there's about 8 small squares, so it's regular, which is important. And there is a P wave for every QRS complex. So next, we can say that, there is a P wave for every QRS complex, but there is PR interval prolongation. Next, we can move on to the QRS, and we can say that the QRS is pretty narrow. We can say that the QRS is a narrow complex. And then the QT. So here we have the Q wave, and here we have the end of the T wave. So just a bit of a shortcut that's not perfect, but a bit of a shortcut in working out the QT. We can say that the QT is less than halfway between one QRS and the other QRS. So it's more than likely a normal QT interval. After the QT interval, we can then look at the axis. And the axis, we can't use the shortcut for this example because 1 is positive, but AVF is actually negative. So what we're going to need to do is look for the biphasic wave. The biphasic wave, well, we have a small complex in AVR. Sometimes just the smallest complex can be the one that you take. Also in lead 2, we have something that sort of looks like a biphasic wave. A bit of a positive deflection, a bit of a negative deflection. So now let's think about the axis. So lead 2 is here at 60. So if this was a perfect biphasic wave, we could say, okay, we're going to add or subtract 90 to 60. In this case, we're not going to add 90 because that would bring us over here. And actually, if we look back at the ECG, we could see that the positive complexes are over on the left side of the heart. 1 was pretty positive and AVL was pretty positive. What we're going to do instead is we're going to take away 90, and that will bring us to AVL. The problem is that if we looked at our complex, it wasn't a perfect biphasic wave. It was actually something more like this. It was a little bit biphasic, but the negative deflection was actually much greater than the positive deflection. So what we can assume is that the axis, the true axis, is actually a little bit further away from AVL. It's more likely to be in this direction. So if we wanted to, we could make a guess and we could say that maybe it's at -45. But really what we can say is that the axis is up in this direction. It's greater than -5, -30, and therefore there is left axis deviation. And also, as we said before, there was PR prolongation. So there's also a first degree heart block. So next, let's move back to where we were going, the ST segment. So the ST segment is important, as we said before, for diagnosing ST elevation, ST depression. Well, not diagnosing it, but identifying it. And where we actually measure, typically, ST depression elevation is at the J point. So the J point is at the end of the QRS, so at the end of the S wave, and at the start of the ST segment. So this right here is the J point. So this is where we measure ST elevation, for example. And when we think about ST elevation, normally we're thinking about a STEMI, so an ST elevation or an ST elevated myocardial infarction, if I can eventually say it. There's different types of ST elevation that we'll see, and this is quite important. Whenever we see ST elevation, we need to be very suspicious that there has been an MI. So it really depends on the clinical context. There are a lot of causes of ST elevation, and we'll go through a few shortly, but I'll show you a few of the different patterns that we can actually see. So one of the most common is upsloping ST elevation. So here we can see that the J point is not perfectly at the isoelectric line, and let's imagine that we have a bit of a gap there that's about 1 millimeters, which typically corresponds to 1 millivolts. So that we have upsloping ST elevation. And in this case, we'd be very suspicious. We'd want to rule out an MI, especially if there was chest pain. Next example, and here, instead of upsloping, we'll have a bit of a gammy QRS, but then we'll have some horizontal elevation, horizontal ST elevation. And finally, we'll have some downsloping ST elevation. So all of these can be associated with an MI. The second two and 3 here, the second two are actually more indicative of an MI. The first one less so. But either way, whenever you see ST elevation, you always want to exclude an MI. Now let's go to the criteria. So this is taken from the European Society of Cardiology guidelines for an ST elevation myocardial infarction, so a STEMI. So here you can see, in the proper clinical context, ST segment elevation at the J point, which we just said, is considered suggestive of ongoing coronary artery acute occlusion when there are 2 contiguous leads with ST elevation. And now in V2 and V3, we have this specific, we have a bit of specific criteria. We have some specific criteria. For men under 40, you need greater than 2.5 in those leads. For men over 40, greater than 2. And for women, you need greater than 1.5. We're not going to focus on this today. We're just going to focus on all the other leads and just greater than 1 millimeter in 2 contiguous leads. So that's what we're going to be looking for. Now, when we think about contiguous leads, what we're looking for is 2 leads that are next to each other in the diagram we've got here. Also, that includes the precordial leads as well. So let's take, for example, if you had ST elevation in lead 3 and AVF. So that would represent 2 contiguous leads, 2 leads that are next to each other in the axis diagram. In this case, it would actually be an inferior MI. It would be suggestive of an inferior acute occlusion. And that's because these leads show the inferior side of the heart. Alternatively, if we had AVL that was positive, that was not positive, that had ST elevation, and lead 1 that had ST elevation, then that would also be 2 contiguous leads. And the same applies for any of the precordials. So say, for example, if you had lead V2 and V3. So AVL and 1 would be a lateral MI, or a lateral acute occlusion. This would be an inferior, as we said. This would be an example of an anterior. We'll get to this in a further lecture. You can also see AVR, and AVR is on its own, and there's not really any contiguous leads for AVR. So AVR is the exception to this rule. You can actually have alone, what's the right word? You can have isolated, there it is, isolated ST elevation in AVR, and you cannot see it in the other leads. We'll get to that in a further lecture because that's a very important sign. But AVR is the only lead where you would not expect contiguous or contiguous ST elevation in the leads that are next to it. So now let's look at an example. So here I'm showing you leads 2, leads 3, and AVF. There's also AVL there. But these are 2, 3, and AVF are the inferior leads. And if you look in lead 2, maybe some subtle ST elevation, but definitely in leads 3, you can see here, and leads AVF, we've definitely got some ST elevation there. So this would be an example of inferior ST elevation. And in this case, this was an inferior MI. This is quite an obvious example of ST elevation, and this is what people call tombstoning here. So this is a classic example of a STEMI, an ST elevation, an acute occlusion. Now I just wanted to list some of the actual causes of ST elevation because it doesn't always represent an acute occlusion or a STEMI. It can actually be a variety of different things. So you can see ST elevation in left ventricular hypertrophy or right ventricular hypertrophy. You can also see it in bundle branch blocks. You can see it in pericarditis. And you can also see it in this entity, which is called benign early repolarization. We're going to talk about how to differentiate this in a later video. But this is actually a normal variant. And this can be seen in young individuals, even healthy individuals. And sometimes it can be quite difficult to differentiate the two. But there we have some causes of ST elevation. So it's not always an acute occlusion. So now we're going to move on to ST depression. So here you can see this is where the ST segment drops below the isoelectric line. Here's a good example of some ST depression. So ST depression, conversely to ST elevation, is indicative of subendocardial ischemia, typically. But there are other possibilities, but we'll talk for now about subendocardial ischemia. Some people think about ST depression, they think about subendocardial ischemia. I'm not very good at writing. Subendocardial ischemia. Some people immediately think NSTEMI, but that's not really the correct terminology until we've got a troponin. When we're looking at the ST depression on an ECG, normally we say subendocardial ischemia. So the difference between the ST elevation in an acute occlusion and the ST depression in subendocardial ischemia is the fact that the injury current is traveling in a different direction. So an ischemic tissue, in ischemic tissue, the charge outside of those myocardial cells will actually be slightly positive compared to the healthy tissue surrounding it. So what you'll have is a current of injury. You'll have charge flowing from the healthy myocardium towards the injured or the ischemic myocardium. And that's what we're actually seeing in ST elevation and ST depression. I'm going to go through that in a later video. But in this case, what we have is electrical current flowing from healthy myocardium on the surface of the heart to injured ischemic myocardium on the inner surface of the heart. So it goes from the outer epicardium to the inner subendocardium, and that is that's when we have subendocardial ischemia, and that's why we see this ST depression. We're going to go through this, like I said, in a different video. But so yeah, there's some example of subendocardial ischemia. In this example, this is actually the example that we just saw for ST elevation. And when we see ST elevation and ST depression in the same ECG, we need to be very careful, because this is actually not subendocardial ischemia. This is actually reciprocal depression. And the reason is, so here we said that this is the inferior leads, here lead 2, AVF, and lead 3. If we look on the opposite side, more or less, we can see AVL. And what happens is AVL projects a mirror image, or not even a mirror image, that's the wrong way of describing it. It's just looking at the injury current from a different direction. So instead of seeing, as we see here, we see the current, the injury current flowing towards the inferior leads. AVL will project the injury current flowing away from it, and therefore instead of ST elevation, what we'll have is some poorly drawn ST depression. So we need to be very careful about actually saying that ST depression is subendocardial ischemia. First of all, we actually want to rule out that it's not ST depression that is reciprocal ST depression, because we may have at some point in the ECG, we may have ST elevation here. That's a good example of reciprocal changes on an ECG, and it's a key finding in the case of an acute occlusion. So here we have some of the causes of ST depression. So we have subendocardial ischemia, reciprocal depression, which we always want to first rule out before we call it subendocardial ischemia, and we can also have it in right and left ventricular hypertrophy, bundle branch blocks, hypokalemia, and again, pericarditis. And finally, here we have an ECG.
So try and use what we've learned so far and figure out what's happening in this ECG.